بسم الله الرحمن الرحيم. الآن سنبدأ في المحاضرة الثالثة بالنسبة للجزء الخاص به في كورس أو روتيشن المسالك البولية. Instrumentation in Urology. We have scopes, we have catheters, we have different kind of modalities that we can diagnose and treat urology patients. If we'll start with the catheters, catheters usually used for evacuating the urine from the bladder. Also, it can be diagnostic by inserting a catheter and measuring the post-void residual urine after giving it a chance for any patient just to void and then to measure the post-void residual. During doing urodynamic study also are using catheters for to put a catheter inside and measure the vesical pressure inside the bladder. We can discuss these urodynamics issues later on. In ICUs, you know, they are putting fully catheter to measure the output. Sometimes you need, as I mentioned in the previous lectures, if you are getting insignificant growth or unacceptable results for urine culture, just you can put a straight catheter in and out and get a sample, urine sample, which will be more accurate than a clean catch urine. We have different type of catheters. According to the material, we have silicone catheters, which is highly resistant to incastrations. Actually, these catheters can left in a place in the urethra, in the bladder, for more than 4 weeks. In some publications, up to 3 months also, because especially if it is 100% of silicone, made from 100% silicone. I don't know why it is not furthering. There is something wrong. Yes, it is working now. There is also plastic catheters, which is we can leave there for just up to 1 week. Actually, this is the plastic ones. We are not advising to leave there for a long time. Post any urologic surgery, post delivery, and if you want to put it for shorter time, less than 1 week, to monitor the output of, or for another reasons. If we'll classify the catheters according to the ways, we have 1-way catheter, 1 lumen only. These catheters usually we are using for just sudden evacuating of the bladder and in and out, I mean. Sometimes if we are using these for urethral dilatation and if there is any structure in the urethra. Sometimes if you want full bladder to send your patient for ultrasound, just you can put a catheter, 1-way catheter, insert inflate or fill the bladder and send the patient for ultrasound. As I mentioned to you before, there is a lot or multiple functions or multiple purposes that we can use this 1-way catheter. We have something we call the clean intermittent catheterization. We'll see this in neurogenic bladder lecture or avoiding dysfunction lectures. Sometimes patient unable to evacuate his bladder, you can instruct or teach him how he can insert a catheter in a clean way to evacuate his bladder every 4 or 5 hours, and by that there will be no foreign body will be inside his body. Yani you will avoid in using indwelling catheters which will let or expose him to high risk of urinary tract infection. Two is catheter, which we know, one catheter for drainage, the other is catheter for inflating the balloon to retain, which is retaining balloon. Three ways catheter, you have 3 ways, one for drainage, one for irrigation for filling, and the other one for the balloon. And this kind of catheter we are using a lot commonly in urology, especially in hematuria patients or post transurethral resection procedures, transurethral resection of the prostate or transurethral resection of the bladder tumor. Again, there is something wrong. I believe we skipped one. Anyway, as I mentioned before, also according to the tip, there is straight tip catheters and there is Cudi catheters. Cudi catheters normal like a Foley catheter, but the tip is curved to accommodate the high bladder neck in the conditions of enlarged prostate in old age groups or patients. You will find the catheter tip curved like this in the tip, just to manipulate the high bladder neck. We also, other than the catheters, we have in urology, as I told you, endourology or scopes in urology. We'll start with the cystoscopy. Cystoscopy is a scope that we can measure or we can examine the urethra and the bladder. It is rigid one. There is rigid and there is flexible ones. This is, first of all, this is the rigid one. It is metallic one that we can insert inside the urethra through the meatus, and we can examine or treat sometimes the urethra and the bladder. Ureteroscopy, we are using ureteroscope for diagnosing and treating the pathology of the ureter, like ureteric stones. Ureteroscopes, this one is flexible ureteroscope. We can go with this scope from the meatus to the urethra, bladder, ureter, up to the kidney, and we can fragment the stones inside the kidney with laser fibers. And this is the last advancement actually in treating stones in urology. I will show you the photo of this scope by the end of this lecture. As I told you, this is after going inside the bladder ureter of the kidney, we need to disintegrate the stones. We have different modalities to disintegrate the stones by using either pneumatic. This actually like hammer effect that you are hitting the stone. We have other than the pneumatic, ultrasonic, using the ultrasonic waves to fragment and suck the fragments of the stones. We have also laser. It is actually very ideal for very large stones or the stones in upper ureter on the kidney, not to push it up back, I mean, to the kidneys. It is a very good modality for disintegrating the stone. And actually we had one kind of lithotripters, hydraulic, we call that hydraulic. Now we are not using it at all. I just was I talked with you about the transurethral resection of the prostate. We have resectoscopes that we can use it for resecting the prostate or resecting the bladder tumors. We have, as you can see in the slide, nephroscopes. We can just puncture the kidney with a Sheba needle and put a guide wire, then doing dilatation and put a sheet, as you can see here, and after that just we can go inside with a nephroscope also metallic rigid ones with eyepiece 6 degrees lens that we can go inside, and there is working channel that we can use it for disintegrating the stone inside the kidney. The puncture usually we are doing in the posterior axillary line to reach the kidneys. As you can see in this slide, as you have here radio opaque shadow. This is a stone and this is the needle. We put inside the needle the guide wire, which you can see it is reached already to the ureter. After doing here, we are doing dilatation, as you can see here, and this is exactly the vision which we are seeing it or watching inside the kidney. This is stones inside the calyces of the kidney. After reaching there by our scope, we start to disintegrate. Actually, we are preferring using ultrasonic modality for disintegration, disintegrate these stones, as it is quicker, more fun, because it is fragmenting, and as I just told you, we can suck the fragments. This is a set, as you can see. This is the nephroscope, forceps, this is dilators, irrigation tubes. Usually, actually, this is great surgery, really great surgery. Before 2-3 years, actually, in Gaza, the doctors used to do open surgery for renal stones. Sometimes there will be flank incision around 30 centimeters just to remove 1 centimeter or 2 centimeter stone, and actually this is very invasive surgery in the form of pain, recovery time, return to work, cost. But now, Alhamdulillah Rabbil Alameen, in the era of the advancement of the endourology, by only 1 centimeter incision we can go inside and we can deal with staghorn stone, which sometimes being 8 centimeter, 10 centimeter, some kidneys being full of stones. We can deal with all these stones. In some cases there will be some residual fragments that we can do lithotripsy, extracorporeal shockwave lithotripsy, or sometimes we can do another puncture later on and finish or clear the stone, the patient from his stones. This is actually the description of the cystoscopy. I don't think it is important for you. Here in this slide you can see actually resectoscope, lenses, the cameras. Before in the previous groups rotations courses, I used to take the students to the OR, and actually this whole lecture I used to give them by touching the scopes. I used to bring scopes there in the OR and let them practically to see it and to touch it. Usually we are using saline to irrigate or to do irrigation during our procedures. In some cases, when we are doing resections or TURP or TURBT, transurethral resection, we and using monopolar as for cutting and coagulation. In that time we used to do hypotonic solutions like a glycine solution. As I told you, now we have in urology also flexible cystoscopy and the flexible ureteroscope. The flexible cystoscope, actually this is a great one, and it is expensive, but it is very beneficial that we can do urethro and cystoscopy under local anesthesia, like you are inserting a Foley catheter. And actually it is outpatient clinical procedure, office procedure that you can follow, and you will see in the oncology. We used to do cystoscopy for bladder tumors or patient with the bladder tumor every 3 months. And this instead of giving general anesthesia every time, just you can do in the office cystoscopy flexible fiber optic, go inside and see if there is any residual or recurrences. You can just give appointment for the patient and to resect this tumor. Ureteroscope, as I told you, we can go up to the kidney and manipulate the stones inside the kidneys there. This is cystoscopy, flexible cystoscope. As you can see, it is flexible one. Actually the learning curve is mildly high because the manipulation is very fine, but with the practice it is very easy, less irritant for the patient under local anesthesia. You can do diagnostic, or in the same time if you want to remove, for example, double G stent, you can put forceps and remove it. Sometimes you can take biopsy. It is a great instrument. This one, as you can see, this is longer than that one, also flexible, that we can reach the kidney from meatus up to the kidney. This is magic surgery, really. It is magic surgery, and in this time in all over the world, actually it is commonly used scope, and it is actually overlapped, or it is more commonly used than the BCNL for stones which is around or less than 2 centimeter or 1.5 centimeter, because without an incision we can go up to the kidney and disintegrate and fragment the stones. This is again the nephroscope, which I explained to you just now. No problem. I will skip this slide, but you know there's a problem in the. I believe we need to wait for some time, then we can change. Yes, this is the nephroscope, which I just told you that we can go through 1 centimeter incision. Here, this is the nephroscope, and this is the graspers that we can remove some fragments from these stones. we discussed, this is the flexible nephroscope. Also we have flexible. Usually we can use the flexible cystoscopy to deal with some stones which we can't reach it with rigid nephroscope, because you know we have sometimes from 8 to 12 calyx in the kidney, that some of these calyces can't be reached with the rigid nephroscope. We can use the flexible to look for another stones in the different calyces. Don't know why it is. Type. We can sometimes doing we can do imaging or contrast studies during doing or while doing cystoscopy or ureteroscope by injecting radioactive material, contrasts, diluted contrast to the ureter. I think in the investigation, the lecture of the investigation, I told you or I showed you one filling defect in the ureter by doing cystoscopy, putting ureteric catheter, injecting these contrast, and we can do some diagnosis. I will skip this, more advanced. Transurethral, I told you, we have resectoscope, we have monopolar and bipolar. We can use two modalities for cutting and coagulation. In monopolar we are using hypotonic solution, in bipolar we are using isotonic saline solutions. We can use this modality for resecting the prostate and the bladder tumor. Actually, this is also a very good advancement in urology, as they used to do open prostatic, simple prostatic tumor before, with the risk of bleeding, blood transfusion, and the other complications that I will let you know in the prostatic enlargement lecture. But 2RB is less invasive. Patient, there is no incisions, less pain, no pain. Catheter you can leave there on irrigation for just 2 days, and then you can remove it and let the patient go home. This is the working element, active working element that you can use for resecting the prostate or the bladder tumor. This is some abbreviation: TURP, transurethral resection of the prostate; TURBT, transurethral resection of the bladder tumor; TUVP, transurethral vaporization of the prostate; and IVUTER visual ureterotomy. This internal visual ureterotomy, we are using cold knife just to cut the fibrous structure which is being in the urethra. This is different modalities to remove the stones fragments. This is we call Dormia basket. Exactly, it is a basket, just we are inserting closed this basket inside the scope up to the ureter, for example. Open it inside and remove the fragments inside the ureter. This is I mentioned to you different modalities for disintegrating the stones. This is a probes for ultrasonic probe to fragment the stones, and that one, upper one, is pneumatic. Thank you very much.